The first question is, how can the family caregivers ensure safety at home?
Sure.
Mm.
So safety is a bit of a passion project of mine. When I spoke recently at the Whistler BC Care Providers Association conference. One of the topics that I wanted to address was the idea of safetyism and the idea that safety is not necessarily the most important thing. When I ask patients what their goals are and what is important to them, it's not often safety that comes up for them. We sometimes are maybe overly focused on safety and allow it to kind of take over as this sacred value and ignore other things that actually matter, like happiness or self-fulfillment or just joy for people to have. So I do think safety is important, but we shouldn't neglect the other things that are important besides that. To get back to the question that you asked, though, there's really multiple components to safety, because when we talk about safety, there's three different things to think of. There's safety of the patient themselves, there's safety of the caregiver or family around the patient, and then there's actually safety of the home care provider. And the three parts to safety are important to recognize that there's a balance between those three things. I think one of the benefits of having trained HCAs on staff, like Gravity has, or I guess on the platform, I should say, is the idea that these HCAs have received training and do have experience in maximizing patient safety at home. So they can recognize potential problems before they happen, the sort of rolled carpet edge that somebody's going to catch their walker on and precipitate a fall, or the toilet that's, backed up into a corner and has a bunch of stuff around it, like one of those toilet paper roll holders that the patient is going to trip on and then fall in a corner where it will be really hard for them to get up. So the HCAs are often capable of recognizing those sort of threats and being able to mitigate them or manage them with recommendations to the family. I often talk about the benefits of experience, that a lot of us, if we're family caregivers, will go through this maybe twice, maybe three times in our life, whereas somebody who's an HCA, this is what they do all the time. This is what they go to work and do. And so being able to have that experience and have that notion of, oh, I remember this being a problem for a patient that I had in the past, I think is really, really valuable. That idea for them to make recommendations is really super useful. That's for them to help with the patient safety side of things. From a family side of things, that's often about managing patients with cognitive impairment or the issues that they can have with potential safety issues. People's personality can change as they get more and more cognitively impaired, and there's a worry there that that can precipitate violence. If that does precipitate violence or worsening even emotional distress for families, then there's often a support network of people available through that home and community care system that I mentioned earlier, with sort of social workers or even physicians available to help both mitigate that behavior for the patient and help support the family through it. I work at the Cancer Agency, I work at hospice as well, and all of these different healthcare agencies often are staffed with some sort of a support network for families. I wish they were better funded, and I wish there was more sort of support available. But at the end of the day, often it's about trying to reach out and trying to say that this is a problem for us as a family and that we're worried about safety. The common scenario that I hear is of an elderly couple where one patient is getting more and more cognitively impaired, and the children are worried about the safety, not of the patient who's cognitively impaired, but of the other person, their partner, who's often their primary caregiver and at risk for harm themselves. And then finally, we talk about safety of the HCAs, the ones that are going out into the patient's home, because again, they're vulnerable both to patients and to families. And we encourage HCAs to sort of, in our case, we encourage HCAs first to contact patients and families by phone and to understand the situation that they're getting into. We've put systems in place in order to kind of mitigate that risk to the HCAs, to have them report back and be able to report back on the Gravity system to say, yes, I'm safe, and yes, this is a safe household to go into if other people are going into that. The other reality of that is that one of the advantages of the platform is that it gives the HCA control, that if they don't feel safe or if they're worried about the situation, they're not obligated to go, that they can decline a service, they can decline a visit and say, no, this isn't something that I feel like doing. It's not worth it to me to put myself at risk. It's not even necessarily sort of deliberate harms that people are worried about, but sometimes the idea that somebody can be like really heavy, and there are some HCAs are going to be fine with helping that person to stand up and use their walker, and they have absolutely no problem with that. And other HCAs are going to really struggle with that if they have issues with their back, if they have issues with pain themselves, or if they're just a really, really small person. We have to recognize some of those physical realities, that different patients match well with different care providers. And that's the sort of benefit of Gravity, is that the patient knows who's going to come in their door, and the HCA knows what door they're going into and who they're going to see behind it.
Yeah, I think that's really important when both parties are kind of choosing each other. That's to me, the way that you ensure safety is, and especially since you get to talk to that person and you get to meet them first, before getting services from them, you get to connect with them and kind of see not only compatibilities from the points of view that you've mentioned, but also personality wise and all that. So yeah, I think
Yeah.
those are really good points.
Yeah. The idea
Okay.
of sort of autonomy and control, like
Hmm.
I'm a physician and I'm granted a lot of autonomy and a lot of control over what happens to patients and what happens to me throughout the day. And one of the ideas is that I think when people are given autonomy and are given control, then they tend to take more ownership and they tend to be, really engaged in an issue. We did focus groups with HCAs before we started Gravity. And one of the things we heard constantly was people being told, that they had absolutely no control, that it was, here's your list of patients that you're going to see today. And you might not know half of them, and half of them might be patients that you can't really work well with because they're, either, as I said, very heavy or difficult to move, or they have aggression issues, but they don't have any control over that. And so the idea of more autonomy for patients and more autonomy for HCAs seem to be beneficial from my perspective.
Yeah, definitely. Okay. The next question is, how can I ensure that my parent or spouse receives personalized and attentive care at home?
Yeah. And it does come back a lot to control. When I'm seeing patients either in community or in hospital and they're talking about the home support workers, they often say, well, they're lovely, but I don't know who's coming through the door at any one point in time. In fact, traditionally, the public home support system has discouraged patients and care aides forming any sort of a relationship. They sort of say that once somebody knows somebody really well, they should be shuffled along to see other patients. And I tend to disagree with that. I tend to think that that relationship is extremely crucial and extremely important for both patients and for the care providers, that there has to be some level of ownership, some level of accountability. And one of the ways that we do that is by having building that personal relationship between the patient and the care provider, so that the patient is the one who's sort of responsible for hiring and paying them. And they can provide that feedback directly rather than having this sort of system where, the patient has no control over who walks in their door, where the HCAs are just given a list of people to see. That, to me, healthcare is fundamentally a relationship challenge. This is a human issue, and humans are built on the relationships that we form. And so the idea of Gravity is kind of actually to take technology and use technology to facilitate a human connection, rather than putting the technology in the middle and saying, well, this is going to replace the human connection. We really want to step back as much as we can and say, well, we're facilitating you touching each other, you connecting. That's the name. Gravity is about people being pulled together, and that hopefully will allow people to not worry about kind of the list of patients that they have to see, or the patients to worry about who's going to walk in their door. It's going to be about, I can't wait to see my care provider because I know them, I know who they are, and I know what they help me with.
Yeah. And I think this really speaks to the continuity of care. Like you mentioned, um, oftentimes people are paired with different care providers all the time, whereas with Gravity, you have the option to stick with the same provider over and over again, or if you have, multiple providers, at the very least, they have those provider notes that are shared between providers that can inform each other of what happened in the last session, or those care provider notes that are very important, and also they're important to the family caregiver as well, to know
Yeah,
what's happened with their parent or spouse during a certain session.
exactly. Yeah, that idea, it's funny, that idea of longitudinal care, that's what family doctors have always been about, the idea of knowing your patients and doing that really well, and of being there for them at all these different stages. And that's, family doctors have done that really well, but they can't be everywhere, and they can't be in the patient's home helping them to get out of bed in the morning. So I see that family doctors still is having a huge role to play in that longitudinal care, but this is sort of an extension of that. And continuity in the relationship is really important. It's one of the things, actually, I mean, I as someone who lives and works in a city now, but used to live and work in small towns, I'm envious of my rural colleagues and the relationship that they get to have. They see their patients as an outpatient, they see their patients when they get admitted to hospital, they see them in emergency, all these different stages. Whereas often when we're working in a city, it's such a big system that we're sort of seeing just little snippets and little pieces, and we can miss that whole story. And I wish it were different. I wish we could learn more from our rural colleagues in terms of being able to be there in all these different settings. Yeah, there's a lot of question marks about technology in healthcare. Again, I was at this care providers conference recently, and a lot of idea about that many of the sort of technological innovations have foundered for seniors, that there was this idea that what we needed to do with seniors was to surveil them, that we needed to monitor them, we needed to put bracelets on them to monitor their heart rate, we needed to have a watch that encouraged them to walk their 10,000 steps. And what we really wanted was to monitor and surveil them. And I would say by and large that has failed. That we trying to use technology to replace human emotion and people has not been a success, and in particular has not been a success in the seniors care space. We tend to forget that seniors are still people, that someone who was once a World War II veteran is not suddenly going to want to be completely surveilled and have somebody watching over them all the time just because they've aged now. That no matter how frail or cognitively impaired someone gets, they're still a person, and they often have opinions about what they want, and it is the very rare person who says that what they really want is to be monitored 24/7. That's not a thing that I find tends to exist. I think the way that technology can work is by taking some of the load off of people, by handling the communication, by handling the sort of coordination piece, so that people can focus on what they do best, which is helping each other and forming those relationships. So having someone try to struggle with building a schedule for healthcare aides, for example, within the health authority or within a private home care agency, I think that's just a bad use of personal resources. It's a bad use of human resources. And what it amounts to is somebody doing a job that I think a computer can do better. Whereas all of those people could actually be seeing each other and managing the connection piece and going into each other's homes. So that's fundamentally what Gravity tries to do, is a technology platform to connect the people together and then to step into the background and basically to facilitate communication and connection rather than standing in the middle and stopping people from doing that. So when we're setting up, for example, the schedule there, that allows people to schedule their own day, to allow them to say, I want 2 hours off in the afternoon to go to my child's concerts, or their kindergarten starts or something like that. That'll, by self-scheduling, people have much more control, and by taking out the additional cost of all of those human resources doing things that computers can do better, then it allows us to really focus on the patient, the caregiver, and the care provider.
Yeah, this makes me think of a quote that I heard in my marketing or design background, and it said something like, technology should be there to enhance our lives, and like you said, step in the background, be as seamless as possible, not get in the way or cause additional problems. Technology should be there to make our lives easier, not to distract us or get in our way. So totally agree with that.
Yeah, it's there to facilitate, not to replace.
Next question is, what steps can I take to make my home safer and more comfortable for aging family members?
Yeah. So there's two sort of ways to approach this, and I often think about this when I'm seeing patients who are getting close to discharge from hospital. And that's about what things do you need to change and what people do you need in place in order to help somebody be comfortable at home. Because those are two different aspects. And with Gravity, we're really focused on the people question and being able to put people into place. When we talk about what things do you need, that's really the domain often of occupational therapists within our public health system in BC. We have occupational therapists on the hospital ward. There's also occupational therapists who work with home and community care and do these things called home safety assessments, where they come into the patient's home and are often recommending these sorts of things like a walker or a raised toilet seat or grab bars in the bathtub in order to help people to basically live their lives and remain at home and remain comfortable there. I think the biggest advice that I would give family members is to start thinking about what somebody needs to do throughout their day in order to be comfortable, in order to be at home. Like, I'll sometimes see people being like, oh, well, they need to downsize and they need to move into a smaller home. And while I would support that if the person actually wants that, I've rarely seen that be successful in terms of if somebody doesn't want to leave their home, they're going to be there and they're going to kind of fight that tooth and nail. And frequently that's a lost cause for the children of aging parents, most commonly. What I would say is the adaptations to allow them to live their life comfortably in the environment where they are the things that help them most. And most often it's the things that are sort of invisible that you wouldn't think about. So think about if you're going in and seeing your aging parent and wondering about how to help them be in their home, then I would try to sort of walk a mile in their shoes, or even walk an hour in their shoes, of waking up in the morning, thinking about how they get out of bed. Like, is their bed up high enough, or do they need an extra box spring underneath that to put their bed high enough so that they can actually get out and stand up? Are they able to move around in their home, or do you need some grab bars on the wall? Because often a lot of older homes especially are not really compatible with walkers or wheelchairs. They're simply too small and the doors are too narrow to be able to get things like that through. So just having something to grab onto on the walls, looking around and looking at safety assessments, things like carpets on the floor, where a carpet on the floor can be a benefit if it prevents someone from breaking a bone as they fall, but it can be a risk if the carpet, if the sort of corners are turned up, if it's a rug that tends to slip around, and assessing that. And I would say that's the fundamental thing to do, is to try to get into the home and try to assess what are the things that would be potentially unsafe. Now, that's an area of expertise. I wouldn't necessarily say that somebody can do this fully, but you can start to get an idea, especially in places that are high-risk areas like bathrooms and kitchens, where people are often having the most difficult events of their day. I would say when we see patients who are in hospital after a fall, over half of the time that's a fall that happened to someone in the bathroom. And so really focusing on those rooms where people have to go, that somebody can't avoid going to the bathroom no matter what, and focusing on those places and trying to make them as safe and as comfortable as possible for your loved one is a thing that I would recommend. And then if you feel challenged with that, then trying to get a consult with an occupational therapist, either one that you can hire privately or trying to ask for a home safety assessment from home and community care, getting that person in to see what help they can provide through the public system, because it can often be really simple things.
Yeah. No, thank you for that. I actually didn't even think about, the older homes having narrower doorways, or even the rugs around the home. I would have not thought about that. So I'm sure some
Yeah.
people will appreciate those tips.
And you know what? Like one of the hard things is people have to be willing to use the things that they're given. I mean, there's a bit of ageism in society, and even old people often don't want to feel old. And I've seen more patients where somebody comes along and says, "Here's a walker, use your walker," and they say, "I don't want a walker. Like I fought in Normandy or something, and here I am being given a walker. It's ridiculous." And so I see people, genuine attempts to help patients, but it has to have buy-in and engagement from the patient themselves. So I mean, I don't know, same situation where if you got somebody, walls that they can hold on to, like grab bars on the walls, or talked with them about why you think they would benefit from a walker, and maybe came to some compromise where you can get them something that's a little bit less sort of obvious, like a cane or something like that, then people can actually benefit from that. Better a cane that someone will use than a walker that someone won't use.
Another question is, what are some signs that my loved one might need professional home care assistance?
Yeah. There's I mean, the people who are doing case managers and are doing home care assessments for the public health have scoring systems that they use. The one that we've adapted for gravity is actually called the independent living scale, and so it's something that allows us to basically assess how independent somebody can be. The one that's most commonly used is something called the functional independence measure. And then when they're actually assessing how much home care people should go into use, it's called the RAI, RAI, and it's something to do with independence or functional status. Ultimately, the things that families will recognize is often a combination of physical or mental challenges. And so if somebody is physically having a hard time mobilizing around their home, if they're having a hard time getting around, or if they are sort of mentally changing and having issues with more and more memory loss or more and more cognitive impairment in terms of personality changes or inability to recognize people that they previously recognized. All of those are indicators to family members that they might start needing more home care assistance. And the reality is that it often takes some sort of a healthcare provider visit, whether it's going to see a family doctor or ending up in the emergency department to kind of make this happen. That it's often sort of those warning signs can go unheeded and somebody can end up really in emergency after a fall or after they're wandering or some other challenge that people have had. I would say the most important part is to actually talk to those people, to communicate with them. I mean, we have a long history of kind of maybe isolating older people and institutionalizing them somewhat, but being able to talk and converse and communicate and visit when we can. I think in particular, when I think of the children of aging parents, those are the things that are most important, that if you remain engaged, if you remain communicative, even despite all of the things that are going on in your own lives, then that can really help. Just noticing what's going on and noticing a change from their previous baseline.
What are you seeing is more common, people being proactive in getting home care or, reacting to an emergency visit or a hospital discharge?
Yeah, definitely reactive, sadly. I mean, it should be different. It should be proactive, but almost always it's reactive. I mean, the people who do best are the ones who are proactive about it, and I've seen patients move themselves into assisted living. I've seen patients hire home care aides before they need it because they wanted to find someone that worked really well for them. I've seen patients, sitting in their 60s and thinking, well, I need to start making adaptations in my home and putting in things like stair lifts or ramps or minimizing the number of stairs that they have. All of these people who are proactive are the ones who are doing the best, in my opinion. But the reality is that we're not very good at being proactive in these things, that we're not very good at preventing things from happening until they've happened. And so certainly most commonly, it's the reactive one. It's somebody ending up in emergency after a fall with a hip fracture, and then a 6-week long period of hospital-based rehab, and then they go home and realize that they can't take stairs.
Yeah. And I think from my own experience as well, just seeing family and friends and talking with people more and more, that's what I'm seeing as well. It's very reactive. And I think usually in life, that's how it happens. Until something happens, we don't do anything, even though we know we might need support in certain areas. So
it's funny, like since starting Gravity, I have these conversations with people about Gravity, and I'm talking to random people like investors or bankers and stuff like that, and they're always just like, oh yeah, and like with my parents it was like this, and everybody has these stories. Like our generation is just chock full of people who are trying to care for aging parents and trying to care for someone and trying to think about what are we going to do if something bad happens. It's really like the challenge of a generation, and I think it's an existential challenge for our generation to try to figure out how we're going to do this without just putting everybody into long-term care or putting everybody into hospitals. I mean, that's not, to me, an answer, and it doesn't keep anyone happy, and it's certainly not affordable.
Yeah. And that's the reality of it too. I think, the stat is 1 in 4 people is currently a caregiver, and then 1 in 2 will eventually become a caregiver in their lifetime. So it's definitely something that we need to talk about and we need to address and be proactive about.
Yeah. And I mean that like talking about it being an existential challenge. I mean, healthcare already consumes nearly half of the budget in British Columbia. And as healthcare consumes more and more resources, that leaves less and less for everything else. That leaves less and less for, child development. That leaves less and less for schools. That leaves less and less for roads and energy development and everything else that we need to do to function as a society. Like healthcare can kind of be this leviathan that overtakes everything. And especially when we look at the demographic changes that we're seeing, that's a real risk that it'll start to degrade not just the healthcare services that people receive, but everything else too. And so we need to find some sort of a sustainable mechanism to allow, family caregivers to have the lead role, to be supported by care providers, and to try ultimately to keep people in their homes as long as they can be happy there and be comfortable there.
Yeah. Okay, awesome. Well, thank you so much for taking the time to answer these questions, and we'll see you back for the next series of Ask Dr. Kevin.
Sounds good. Thanks, Tia.
Okay, thanks. Kevin.